Approach to paroxysmal supraventricular tachycardias. MV Jorat MD 1389. Definition: Narrow QRS complex supraventricular tachycardia, SVT, is a tachyarrhythmia with a rate more than 100 beats per minute and a QRS duration of less than 120 milliseconds. A narrow QRS complex, less than 120 ms, reflects rapid activation of the ventricles via the normal His-Purkinje system, which in turn suggests that the arrhythmia originates above or within the atrioventricular avenue, node, a supraventricular tachycardia. Differential diagnosis of narrow QRS complex tachycardias. Sinus tachycardia. Inappropriate sinus tachycardia. Sinoatrial nodal reentrant tachycardia, SNRT. Atrial tachycardia, AT. Multifocal AT. Atrial fibrillation, AF. Atrial flutter, AFL. Junctional ectopic tachycardia, JET. Non-paroxysmal junctional tachycardia. Atrioventricular nodal reentrant tachycardia, AVNRT. Atrioventricular reentrant tachycardia, AVRT. Sites of origin in supraventricular tachyarrhythmias. Tachycardia narrow QRS tachycardia wide QRS tachycardia regular. Irregular. Avenue node dependent. Avenue node independent. AF, AT/AFL with variable avenue conduction, multifocal AT. Sinus tachycardia. Junctional tachycardia. AT. AFL. AVNRT. AVRT. The estimated prevalence in the normal population, 2.25 1/1000ths. Paroxysmal SVT is the term generally applied to intermittent SVT other than AF, AFL, and multifocal AT. The major causes are AVNRT, approximately 50% to 60% of cases. AVRT, approximately 30% of cases. And AT, approximately 10% of cases. The estimated prevalence in the normal population, 2.25 1/1000ths. Incidence, 35 100,000ths person years. Age, in the absence of structural heart disease it can present at any age but most commonly first presents between ages 12 and 30 years. Sex, females/males, 2. Proportion of paroxysmal supraventricular tachycardia mechanism by age. This trend is similar for both gender. Initial evaluation. History, physical examination, and an ECG constitute an appropriate initial evaluation of paroxysmal SVT. Clinical symptoms are not usually helpful in distinguishing different forms of paroxysmal SVT. Different methods of electrocardiographic evaluation helps for detection of arrhythmias. Clinical presentation. Onset and offset. Abrupt or gradual, warm-up and cool-down, onset and termination of palpitation. Abnormal iomacity or reentrant mechanism. Duration, from minutes to several hours. Commonly is associated with dizziness. Rapid ventricular rates can be associated with dyspnea, weakness, angina, or even frank syncope, and can at times be disabling. Neck pounding, AVNRT. Patients often learn to use certain maneuvers such as carotid sinus massage or the Valsalva maneuver to terminate the arrhythmia. Physical examination. In patients without structural heart disease, the physical examination is usually remarkable only for a rapid, regular heart rate. At times, because of the simultaneous contraction of atria and ventricles, Canon-A waves can be seen in the jugular venous waveform. In patients with an AT exhibiting avenue block, usually of the Wenckebach type, The ventricular rate is irregular. An echocardiographic examination should be considered in patients with documented sustained SVT to exclude the possibility of structural heart disease. Exercise testing is less often useful for diagnosis unless the arrhythmia is clearly triggered by exertion. Invasive EP testing with subsequent catheter ablation may be used for diagnosis and therapy in cases with a clear history of paroxysmal regular palpitations. Clinical history of palpitation. 12-lead ECG in normal sinus rhythm. Pre-excitation. Yes. No. Suspected to AVRT. AS's arrhythmia. Pattern by clinical history. Irregular. Palpitation. Suspected AF. MAT. AFL or IT by. Variable block. Syncope. Sustained. Regular palpitation. Event recorder. And follow-up. Refer to electrophysiologist. Electrocardiographic features. Ambulatory 24-hour Holter recording may be used for 12-lead ECG. 12-lead ECG only during tachycardia can be helpful for defining the mechanism of paroxysmal SVT. Ambulatory 24-hour Holter recording may be used for documentation of the arrhythmia in patients with frequent, i.e., several episodes per week, but self-terminating tachycardias. A cardiac event monitor is often more useful than a 24-hour recording in patients with less frequent arrhythmias. Implantable loop recorders can be helpful in selected cases with rare episodes associated with severe symptoms of hemodynamic instability, for example, syncope, heart monitoring options. 12-lead. 10 seconds. Holter monitor. 2 days. Typical event. Recorder. 7 days. Macot external. Loop recorder. 30+ days. ILR. 36 months. ILR equals insertable loop recorder. Macot equals mobile cardiac outpatient telemetry. 16. Typical wearable event recorders. 17. External mobile cardiac outpatient telemetry, MCOT, ECG recorder. PDA stores ECG data and symptom status. Wireless transmission capability provided. Patient indicates symptoms on PDA. Abnormal ECG transmitted automatically. Monitor center receives, reviews and transmits data to physician. Predetermined urgency criteria determine timing of physician alerts. Physician receives and acts upon data as medically appropriate. CardiaNet Incorporated, San Diego, California. 18. Insertable loop recorder, ILR. An ECG monitoring system that is implanted subcutaneously. Capable of recording, storing, and if necessary remotely transmitting ECG signals. Patient activated and are automatically activated. Longevity of current ILR is up to 36 months. Indicated for patients with unexplained syncope, block. Patients who experience transient symptoms that may suggest a cardiac arrhythmia. Patients at increased risk of cardiac arrhythmias. 19. Insertable loop recorders, ILR. Reveal system. Medtronic Incorporated, Minneapolis, Minnesota. Manual/auto trigger. Remote download, Care Link. Sleuth. Transoma Incorporated, St. Paul, Minnesota. Manual/auto trigger. Wireless data transmission. Confirm. St. Jude Medical. St. Paul, Minnesota. Manual/auto trigger. Remote download. 20. ILR symptom rhythm correlation, case examples. These are examples of ECG recordings obtained by the Reveal ILR system in 2 symptomatic patients. The gold standard for determining if a syncope episode is due to an arrhythmia is to record the rhythm during symptoms, symptom-rhythm correlation. The ILR may help rule in or rule out arrhythmogenic causes. These strips depict findings from an ILR interrogation as they appear on the programmer screen. In order to view the event in greater detail, one taps the screen over the ECG of interest. On-screen calipers are available at every zoom level to measure cycle length in milliseconds or beats per minute. Note that the A represents an auto-activated event, the P indicates when the patient activated the device. Upper strip, infrahision avenue block, dual-chamber pacemaker. Lower strip, VT and VF, ICD, meds. Case, 56-year-old woman with refractory syncope accompanied with seizures. Case, 65-year-old man with syncope accompanied by brief retrograde amnesia. Medtronic data on file. 21. Baseline ECG evaluation. Baseline ECG. PR dispersion for determination of pre-excitation. Tracings from the 12-lead ECG illustrating the principle of PR dispersion. Lead 2 has the least pre-excited QRS complex with the longest PR interval, 180 ms. Whereas lead V5 is the most pre-excited with the PR interval of 100 ms. Thus, the PR dispersion was calculated as 180/100 equals 80 ms. Use AVR for exclusion of pre-excitation. 4 patterns of the QRS complexes in lead V6 and corresponding patterns in lead AVR in the same patient. Positive delta wave obscuring septal activation. Isoelectric delta wave resulting in pseudoseptal R wave. Overt pre-excitation without any isoelectric line between P wave and positive delta wave. Manifest septal Q wave. Stepwise algorithm to exclude or confirm pre-excitation on a 12-lead ECG. Europus, 2010, 12, 119-123, Identification of the atrial activity during arrhythmia. Most SVTs are associated with irregular ventricular rate. If the rhythm is irregular, the ECG should be scrutinized for discrete atrial activity and for any evidence of a pattern to the irregularity, for example, grouped beating typical of Wenckebach periodicity. If the rhythm is irregularly irregular, i.e., no pattern can be detected, the mechanism of the arrhythmia is either multifocal AT or AF. Multifocal AT is an irregularly irregular atrial rhythm characterized by more than 3 different P-wave morphologies. The P-wave separated by isoelectric intervals. Varying PP, RR, and PR intervals. Multifocal atrial tachycardia. Atrial fibrillation. AF is characterized by rapid and irregular atrial fibrillatory activity and, in the presence of normal AVN conduction, by an irregularly irregular ventricular response. P waves cannot be detected in AF, although coarse fibrillatory waves and prominent U waves can sometimes give the appearance of P waves. The fibrillatory activity sometimes is so fine as to be undetectable. Atrial fibrillation. Chronic AF. Paroxysmal AF. Now QRS tachycardia. Regular tachycardia. Visible P wave. AF, AT/AFL with variable avenue conduction, multifocal AT. Atrial rate ventricular rate. AFL or AT. Analyze RP interval. RPPR, short RP tachycardia. RPPR, long RP tachycardia. RP interval less than 70 ms. RP interval greater than 70 ms. At PJRT. Atypical of NRT. AVRT of NRT at. Typical of NRT, identification of the atrial activity. If the patient's rhythm is regular or has a clearly discernible pattern, the ECG should next be assessed for P waves, atrial activity. The P waves may be easily discernible, however, frequently, comparison with a normal baseline ECG is needed and can reveal a slight alteration in the QRS/ST segment, or T or U waves, suggesting the presence of the P wave. If the P waves cannot be clearly identified, carotid sinus massage or the administration of intravenous adenosine may help clarify the diagnosis. These maneuvers may also terminate the SVT. Atrial flutter. P wave in sinus rhythm and during SVT. Carotid sinus massage. Temporary decrease in the atrial rate in patients with sinus tachycardia. Automatic HAT. Slowing of AVN conduction and AVN block, which can unmask atrial electrical activity, that is, reveal P waves or flutter waves in patients with AT. AFL, CSM during AT. Carotid sinus massage. 3. With some SVTs that require AVN conduction, especially of NRT and AVRT, the transient slowing of AVN conduction can terminate the arrhythmia by interrupting the re-entry circuit. Less commonly, carotid sinus massage can cause some ATs to slow and terminate. 4. In some cases, no effect is observed. Adenosine administration. Adenosine results in slowing of the sinus rate and AVN conduction. In the setting of SVT, the effects of adenosine are similar to those seen with carotid sinus massage. For intravenous adenosine administration, the patient should be supine and should have ECG and blood pressure monitoring. The drug is administered by rapid intravenous injection over 1 to 2 seconds at a peripheral site, followed by a normal saline flush. The usual initial dose is 6 mg, with a maximal single dose of 18 mg. If a central intravenous access site is used, the initial dose should not exceed 3 mg and may be as little as 1 mg. Adenosine can precipitate AF and AFL because it shortens atrial refractoriness. In patients with Wolff-Parkinson-White (WPW) syndrome and AF, adenosine can result in a rapid ventricular response that can degenerate into VF. Use of adenosine for diagnosis and termination of regular SVTs, including AVRT, is appropriate as long as close patient observation and preparedness to treat potential complications are maintained. Termination of the arrhythmia. Carotid sinus massage or adenosine can terminate the SVT, especially if the rhythm is of NRT or AVRT. A continuous ECG tracing should be recorded during these maneuvers, because the response can aid in the diagnosis. Termination of the tachycardia with a P wave after the last QRS complex is most common in AVRT and typical of NRT and is rarely seen with AT. Termination of the tachycardia with a QRS complex is more common with AT, atypical of NRT, and permanent junctional reciprocating tachycardia, PJRT. If the tachycardia continues despite development of avenue block, the rhythm is almost certainly AT or AFL, AVRT is excluded and of NRT is very unlikely. Spontaneous termination during AVRT. Atrial rate. An atrial rate more than 250 beats per minute is almost always caused by AFL. However, overlap exists, and AT and AVRT can occasionally be faster than 250 beats per minute. AVRT tends to be faster than AVNRT and AT. P-wave morphology. P-wave morphology identical to sinus P-wave. Sinus tachycardia. Inappropriate sinus tachycardia. Sinoatrial nodal reentrant tachycardia. At arising close to the region of the sinus node. An abnormal P-wave morphology. AVNRT, P-wave is concentric. AVRT, P-wave can be eccentric or concentric. AT, P-wave can be eccentric or concentric. AFL, lack of distinct isoelectric baselines between atrial deflections is suggestive of AFL but can also be seen occasionally in AT. The P-waves may not be discernible on ECG, which suggests typical AVNRT. Less commonly, AVRT, especially in the presence of bundle branch block, BBB, contralateral to the VT. Characterization of the P/QRS relationship. RP/PR intervals. SVTs are classified as short or long RP interval SVTs. In short RP SVTs, the ECG will show P waves inscribed within the STT wave with an RP interval that is less than half the tachycardia RR interval. Such SVTs include typical AVNRT, most common. Orthodromic AVRT. AT with prolonged avenue conduction. Slow AVNRT. A very short RP interval, less than 70 milliseconds, excludes AVRT. RP interval. Typical AVNRT. Because of the relatively simultaneous atrial and ventricular activation, the P wave may distort the initial portion of the QRS, pseudo-Q, mimicking a Q wave in inferior leads. Within the QRS, inapparent. Distort the terminal portion of the QRS, pseudo-S wave in inferior leads or pseudo-R in V1, AVNRT. AVRT. Long RP SVTs include, at atypical, fast-slow, AVNRT. AVRT using a slowly conducting avenue BT, for example, PJRT. If the PR interval during the SVT is shorter than that during normal sinus rhythm, NSR, AT and AVRT are very unlikely, and atypical AVNRT, which is associated with an apparent shortening of the PR interval, is the likely diagnosis. ATs originating close to the avenue junction are also a possibility. Long RP atrial tachycardia. PJRT. AV relationship. SVTs with an AV ratio of 1, equal number of atrial and ventricular events, include AVNRT. AVRT. AT. AV ratio during the SVT of more than 1, indicates the presence of avenue block and that the ventricles are not required for the SVT circuit. Excluding AVRT. Suggesting AT, most common. AVNRT, rare. QRS morphology. The QRS morphology during SVT is usually the same as in NSR. Functional aberration can occur at rapid rates. Functional aberration occurs frequently in AF, AFL, and AVRT. Is less common in AT. Is very uncommon in AVNRT. 240 msec. 270 msec. Electrophysiologic testing. Goals of EP test: evaluation of baseline cardiac electrophysiology. Induction of SVT. Mode of initiation. Atrial activation sequence. Effect of BBB on arrhythmia. Arrhythmia circuit components. Ablation of arrhythmia.